Everyone. Welcome to ToniTime, where solutions are just a discussion away. I'm Toni Land, founder and chief experience officer for Landing Exceptional Experiences, and your host of ToniTime. So today we're going to dig right in to a couple of Reddit posts, and they're really centered around incivility in healthcare, rudeness, verbal abuse, workplace violence. So that's what we're focusing in today. And if you saw the thumbnail and that's what made you click on this, we are talking about this and it is unacceptable. So I'm gonna give you two Reddit threads and then we're gonna roll right into those responses. So the first one was from a medical Reddit thread, and they said, no, I'm not ignoring your pain by not prescribing antibiotics for a 2-day sore throat. Yes, I'm happy you got out of the hospital after your severe TBI from a motorcycle crash, but no, I'm not going to pass your DOT at this time. I understand that your child has ran track for years and he's been fine, but his answers to my questions give serious concerns about his health, and I can't let him play. I mean, this is all super obvious stuff, and people just want to be belligerent a-holes about it. Another thread from a different post. Today, a family member chewed me out for leaving her aunt sitting in urine for 30 minutes. Like, ma'am, my other patient's alarm was going off and my tech was taking her lunch break finally at 1700. So you can F right off. Also, this family member is a CNA and was in the room with the patient's daughter. If it's that bad, then could they not do it themselves? Who do they think is going to do it when the patient discharges? Pray for me because today was one of 5. How do you guys cope with this kind of stuff? And so let's look at some of the kind of comments and then listen to what some of the people were saying. One person said, I recently transferred to days, and dealing with more family like this has been the hardest adjustment. It's so hard to bite your tongue. I mean, I had a Q2 turn patient who had around 8 visitors at a time in her room, and the daughter had the audacity to call on the call light on the hour. It's time for my mom to be turned. It's been 2 hours. I finally had to tell her we have multiple patients who are turned, and it doesn't matter. It doesn't mean that they will happen right on the time written on the board. I'm so sorry you have a few more shifts to deal with. I honestly just rant to my coworkers at the desk and hope my families don't hear me. Somebody else said, I know people talked about biting their tongues, but I don't think we should have to bite our tongue. Healthcare needs to stop being treated like customer service. I'm beginning to quickly be honest with patients and their families, because at the end of the day, we have to be firm with those kind of people. Otherwise, other patients get neglected. Somebody responded and said, yes, expectation management is key to dealing with family members, especially those who volunteer that they work in healthcare. I had a family member come to the nurse's station and say to me, chop, 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 while clapping at me as I was walking into the room to help them to the bathroom. My coworkers were asking how I kept calm and didn't chew her out. I'm gonna tell you what, people are a-holes, and I'm sorry you had to deal with one today. I don't really know the answer. I try to explain to those people that we have other patients and some who are really sick, but it doesn't work with everyone. You had a psych nurse say, I'm psych, so I'm brutally honest with families. I had a really, really rude family member once, and I said to him, you're being incredibly rude and I don't appreciate it. We both have the same goal here, to help your father. So work with me, or this is going to be a really rough journey. Guess who is my BFF at the end of the patient's stay? A physician said, I'll let my patients know that I do not tolerate being yelled at, and I either end the phone call or the patient visit immediately. Set your boundaries. And an LPN responded to that and said, MDs have a lot more sway in being allowed to do this kind of thing. I could do it maybe once or twice a year before management would have a serious talk with me. This would never fly if a nurse in long-term care did it. I'm told ignore it, or that it's pretty much neglect, and that by leaving, we increase their risk of injury because they might attempt to do something that they can't do, like fall or worse. It also increases the chance that they pull out their cell phones and call and report neglect. And we're told that this is the patient's way of expressing their frustration, which is something that needs to be addressed immediately. I mean, it doesn't matter what they're yelling. Management absolutely will side with them. I've heard patients yelling about N-words to Black staff, telling pregnant people they hope the baby dies, mocking staff, making fun of the staff's looks, weight, clothing, or disability, sexual stuff. It doesn't matter. And people want to know why we're short-staffed. And somebody said this: it is my job to take care of you and your husband. It is not my job to tolerate your abuse. You'll stop yelling or I'll leave, and we can continue this conversation after the nice police officer has put you in cuffs, and I'll happily press charges for interfering with me performing my duties. And then someone said, I think this has to do with the culture of medicine shifting from paternalistic to more like customer service-esque. And this person said, please note, I acknowledge the shift is due in part to, ethical violations of some physicians before us, especially regarding vulnerable populations. I also feel from talking to lay people that they don't understand what we do. Many people don't understand that we are held to standards of care, and they think we can just YOLO and do whatever. Or in some cases, there are things we should not do, even though we could. So interesting conversation there, as many of your healthcare professionals talked about a lot of verbal abuse from patients and or their family members. So when you look at the data, OSHA says that over 75% of workplace assaults reported annually in the United States took place in hospitals and other healthcare and social service settings. So 75%, that's a large number of workplace assaults. The average healthcare worker was 20% more likely to experience violence at work than the average employee. And that was according to the National Crime Victimization Survey. Now, the ANA reported that 1 in 4 nurses have been physically assaulted by a patient or a patient's family member. Now, I wanted to look back and see what's the common definition that's used out there. And so here's one from the Joint Commission, that workplace violence and assaults, it's an act or threat occurring at the workplace that can include any of the following: verbal, nonverbal, written, or physical aggression, threatening, intimidating, harassing, or humiliating words or actions, bullying, sabotage, sexual harassment, physical assaults, or other behaviors of concern involving your staff, licensed professionals, patients, or visitors. So you can see that's pretty all-encompassing there. It includes everything from verbal to nonverbal, physical aggression, bullying. So not just the reports that we hear of, violence where maybe someone has gotten shot in a healthcare setting. It includes even more than that. So when we talk about the impact of verbal abuse, it impacts our team members, and it impacts the care experience for our patients. Some of the research even said that nursing assistants and nurses had the highest injury rate per 1,000 full-time FTEs. And I don't think that's as surprising, because those are the two professionals that are hands-on with the patient the majority of the time, whether in that long-term care setting, home care, or if you're in an acute care setting. So speaking of home care, looking at some data where they had done some interviews and had a review with home care aides, that when they report verbal abuse within a year, they found that team member was 11 times more likely to also report physical abuse. And I've worked in home care, and it is a totally different world when you are going into their space in order to provide them care. And imagine how threatening that can be when we talk about verbal abuse and physical abuse. Violence committed against healthcare workers, it's not just limited to hospitals. Just as we saw above when someone was there talking about experiences in the long-term care setting, and especially a lot of that verbal abuse. But, the data and research does show us that it occurs in outpatient clinics, during patient transport, and in pharmacies. So really the work that we're talking about applies to every single person who works in your organization, who chooses to serve in your organization. And how do we protect them and be as proactive as possible in preventing some type of workplace violence and abuse towards our own team members? So as we talk about that violence committed against healthcare workers in all the various settings, it is also interesting to add that almost 72% of reported workplace violence is verbal, and 28%, give or take, nonverbal, and most of that being physical. So looking at how do we then start to work towards improving this experience for our own team members, which also will impact the outcomes for patient care. So I tried to look up some articles to see, what is that impact on care? And so it was an article with NICU team members, and it said the rudeness from the family members had an adverse consequence on diagnostic and procedural performance of these NICU team members. The healthcare worker, as you can imagine, well-being, I think that's common knowledge for us, but I don't want to go without saying it either, that well-being is also impacted for our own team members or the healthcare worker. So even minor moments of incivility, and I'll include these article links below so that you can research those, but even minor moments of incivility can accumulate and erode staff morale, reduce confidence, and negatively impact well-being of your own team members, which may contribute to burnout and turnover, or not only that intent to leave the organization, for many, an intent to leave the profession. So there was a study that showed us that incivility decreases the nurse's ability to provide patient-centered care and to communicate compassionately with patients. And so, the research does show that, although at the same time, when we think about it, when someone has been so rude to you, you're the patient or the family then it is hard to respond compassionately and communicate compassionately. And so definitely something for us to work on as we talk about compassion being one of those foundational elements of effective communication. So it's interesting that a study found that incivility decreased the nurse's ability to provide patient-centered care and communicate compassionately with patients. And so that's something for us to think about when we're talking about impacting some of these communication measures, whether it's courtesy and respect, or whether it's communication around discharges, communication around medications. It is that compassionate communication that enables patients and families to really hear what we're trying to share. And that's jeopardized when there are those moments of incivility and rudeness. So the research strongly supports that rude statements result in adverse consequences, both in diagnostic and in intervention performance of the teams. So when we talk about even the team's processes were negatively impacted, including information and workload sharing, as well as helping and communication. So all those things in the way the team functions was negatively impacted due to incivility and rude statements. So what do we do with all that? Now, if it's your first time watching one of my videos, you will see I always talk about co-design. I feel like it is so important in order to effectively create change in your organization. So that co-design, where you are bringing together and here a very diverse group of team members, recognizing, as some of the literature was telling us, whether you're in transport, radiology, lab, the pharmacy, if you're in the acute care side, if you're in long-term care, who are your key players here? Your LPNs, your leadership, your aides or techs, bringing that group together. In the medical practice, bring together front office, some of your front office professionals, along with maybe if you have APPs, bring those folks in. Child life, if you're in pediatrics, bring everyone representation to the table so that you can co-design around what do you do when incivility is happening, and what do you do to try to prevent incivility and rudeness and verbal abuse from happening in your organization. So I would say take some of this literature, the links that are below, and of course, there's so much more out there, but take some of this literature and this video and share it with this co-design team, so that they can start leaning in and learning what's out there, what's already been done, why this is important, not only to them personally and their own well-being, how it's important to the team, and how it's important to the patients and families that they serve. Now, I thought it was interesting, you'll see in one of the literature links that there is even a list of risk factors based on a literature search and lessons learned. And just to name a few of them, it's everything from patient-related factors like complex family relationships, staff who are working in isolation. Maybe there's a history of gang activity. Maybe the team doesn't have access to emergency alerts, inadequate on-site security, and altered mental status from your patients, and or maybe even a family member. And so what I've seen, and I'd love to hear from you, what I've seen is maybe some organizations will post some things for family members. I would say many family members do not read them. They have de-escalation training, so we know how to de-escalate, which means that something is already happening in order for us to de-escalate it. And many have elevated security, whether that's truly number of security officers in the organization. Many actually carry weapons also. There's detectors when you come into the various facilities. Most have signs up saying that no guns are allowed. So we've seen some of those things happen in the organization. I will also say one of the things that came to mind for me that I've not seen happen, so I'd love to know from you, is this happening in your organization? And that's, are we setting expectations on acceptable behavior? And so I think, a new patient coming into a practice, one of the things that we talk about is expectations from them, everything from, yes, no shows and being on time for your appointments, those kind of things, but also how we are expected to communicate to each other with courtesy and respect. And so if you're in the long-term care facility, and whoever's bringing that patient in, that you're talking to that family member, and hopefully that patient, if there's not mental incapacity there, around what is acceptable behaviors and what happens when you violate that acceptable behavior. Just as there are consequences for me violating that behavior, there should be consequences for the resident, the patient, the family member also, and in the home care setting. The same thing, if I'm onboarding a patient that has been discharged and I'm onboarding them into private duty nursing, or maybe it's visits, whatever the need is, that part of that is also setting the expectations on acceptable behavior. And I think some of that is also in your co-design, where you're also including some family members in there from each one of these spaces, depending on what you're working on, so that then you're saying, yes, we want to know what to do when an issue has already come up and there's incivility and rudeness and verbal abuse. But how do we set expectations on the front end also around verbal expectations back and forth for courtesy and respect? So I'd love to know, has anybody done that yet? Has anybody set some of those expectations on acceptable behavior? Comment below. Let us all know. Yes, you are. No, you hadn't thought about that yet, so that we can all chime in and learn from each other. So ToniTime is brought to you by Landing Exceptional Experiences. We are a group of patient experience certified professionals and Leapfrog certified coaches who focus on partnering with organizations to improve patient experience measures along with improving Leapfrog Hospital Safety Grades. There's a link below for you to click on and schedule your free 30-minute consultation. I'd love to talk with you and explore where you might have some low-hanging fruit, and we can move your organization forward on not only improving patient experience measures, Leapfrog Hospital Safety Grades, but improving the well-being and outcomes for your patients, your families, and your team members. So I'm looking forward to talking to you soon. Now, don't forget to comment below, like, subscribe, and share. This has been ToniTime, where solutions are just a discussion away.